My name is Jennifer Sahatchian, and I am the Associate Director of Clinical Affairs Medication Delivery at Baxter International. I am pleased to introduce Dr. Douglas Hansel. Dr. Hansel has a long history in hemodynamics and fluid management in both academia and industry. He is currently VP and Head of Medical Affairs Medication Delivery at Baxter International. In addition, he holds clinical and teaching appointments at Massachusetts General Hospital and Harvard University in Boston. He is boarded in both anesthesiology and internal medicine and fellowship trained in cardiac anesthesia. Dr. Hansel holds a master's in public health from Harvard University and is a senior author on the recently published FRESH study. As a colleague, he is an absolute pleasure to know. I will now turn the presentation over to Dr. Hansel.
Thank you, Jen, and welcome everybody. I appreciate you guys, everyone taking the time to spend with us here, to spend a little bit of time talking about IV fluid. And I think IV fluid is an interesting concept because it's an interesting topic. This is a drug that has been around for over 150 years, and yet we're still learning today how to optimize this drug, both in which drugs we choose and which solutions we choose, as well as how we dose these to bring benefits to our patients today. And what I want to do is spend a little time going through some of the more recent evidence that really sets the stage for a relook at the way in which we use these medications to treat and optimize our patients. So why don't we go ahead and jump in. One of the things that I think all of us as clinicians intuitively understand is this curve that's here in front of us. And what we know is that if you give too much IV fluid, you get into problems of volume overload, tissue edema, and organ failure. Increased ICU stays. Likewise, if you're in a critical situation and you're trying to expand a patient's blood volume, not giving enough fluid, on the other hand, can also cause problems with tissue hyperperfusion and hypoxia. So we know that there's this important sweet spot that we're trying to get to. I think what is different today is that we're learning getting to that sweet spot is probably more important than we've ever appreciated before. And there's new techniques and new technologies that allow us to arrive at that sweet spot. I want to set the stage for this by going through some of the more recent literature on fluid management and the risks associated with fluid management. One of the things that's always been raised is, does our choice of fluid, does the way in which we dose fluid, the way in which we use it, actually cause direct harm, or is it simply the matter that we're using these in patients that are severely ill, and the mortality or complications we see are simply related to their comorbidities and the severity of illness? And I want to point to two more recent works here that really begin to tease out this fact that no, fluid in and of itself is an independent predictor of mortality. There were two studies that were done. One was done by Paul Merrick, and we were part of this. And what it showed was we looked at 23,500 patients with severe sepsis and septic shock who were admitted to the ICU through the emergency room. And we looked at their fluid management. And we did a propensity analysis where we adjusted for patient comorbidities, patient disease factors, and risk factors. And what we saw was that on day one, fluid averaged about 4.4 liters, and average length of stay in the ICU for these patients about 5.4 days. Typical data that's elsewhere reported in the literature. But what we saw with the propensity analysis was actually quite interesting. For each liter over 5 liters of fluid on day one, mortality began to climb by 2.3%. And this is represented in this lower graph here, of the green being the predicted mortality that you would see based on amount of fluid administered. And you begin to see this separate out here over 5 liters. And so at 6, 7, 8, 9 liters, you really begin to associate increased mortality related to fluid, which is unrelated to other patient factors that were included in the model. Similar work was done in a surgical setting. And here, this was looking at 36,000 patients with major abdominal surgery. And again, while the colors are reversed, the green being the actual mortality incurred versus the gray, which would be expected from the propensity analysis in the model, you begin again seeing this diverge at about 6 liters or so on day one of surgery. And you'll see that mortality again increased about 2% for every liter above 6 liters. And certainly other work that was done here too began to show that pulmonary and cardiac complications actually started going up after about 5 liters. So this concept is, does fluid cause direct harm when it's overdosed or used excessively? And the answer to that, I think as we look at the literature and we begin to look at more at experiences, yes. And so we want to make sure that as we're doing this, this concept of load them up, take it off later, yeah, that really doesn't work so much. And we need to stop doing that. We actually need to get better at dosing fluid up front. And I think there are some techniques to go after that, which we're going to spend a little bit of time on. This really raises the question, others also, is does the type of IV fluid matter? And there is a built-in case in the literature for balanced crystalloids over normal saline. When we look at these IV fluids that we administer and we give, you'll see that we typically, stepping back, why do we give IV fluids? Well, we give IV fluids to increase blood volume and expand circulating plasma volume and improving perfusion in that way. And so we're giving these drugs to expand plasma and the blood volume. And when we look at the osmolarity and the content of what normal plasma is like, you'll see that what we down here at the bottom, when we look at normal saline, with 154 milliequivalents of sodium and 154 milliequivalents of chloride and an osmolality of 308, it is anything but normal saline. In fact, it's often sort of called abnormal saline, if you will. Certainly, we're putting in a lot more chloride than what's in the plasma. And with this, what we see is a hyperchloremic metabolic acidosis. And there's certainly animal work that's been done that shows this decreases renal perfusion. And there's a built-in literature here that I'll just touch on briefly that shows that this indeed, using sodium chloride, may not be as safe or as efficacious in certain patient populations as using more balanced solutions here, such as lactated ringers or the more advanced IV fluids such as Plasmalite or others that are balanced not so much with lactate but with gluconate or acetate to reach the osmolality. And again, you'll see that the osmolality here, these solutions are much closer, if you will, to the osmolarity of plasma. So these IV fluids, they are different. They're made up, they're compounded in different ways, and we should be thinking about them differently as we use them. Certainly when you're going for a large volume, blood volume re-expansion, you want to be thinking about probably plasma, more plasma-like agents than what we see with normal saline. So what is the data on this? And it's evolving, and I think there's some, as I said, interesting data coming out. Just going over some more recent trials, the SPLIT trial was an ICU-based trial looking at almost 2,200 patients, almost 2,300 patients. And all of these studies that I'm about to go through, just very quickly, you'll see that definitely shows a balance towards or favors the balanced solutions as opposed to using normal saline when it comes to mortality. The SALT trial was also an ICU trial, and two large-scale trials that were done with crossover techniques, the SALT ED and the SMART trial. Again, now we're pushing almost 30,000 patients in this, again, lining up and continuing to sort of show the favor of balanced solutions versus saline. Some of the challenges in doing these trials, and I think this is where the latter trials with SALT and SMART really became much better at this, is also controlling the amount of and the type of solution that's given before the trial begins. And so SALT and SMART started typically in the emergency room, and the same type of fluid was carried through these cases. So these can be a little bit logistically challenging to do, but certainly as you begin to look at the evidence building in these cases, certainly it's tending to favor more balanced solutions. Two studies that are coming out to keep our eyes out, they're coming out around the corner here. There's a PLUS study coming out of Australia, New Zealand, it was designed to look at 8,800 patients. Unfortunately, with COVID, I think they've scaled their enrollment back, and that will be coming out about 5,700 patients or under 6,000. So it'll be coming out slightly underpowered, but hopefully that will add to the database here of studies that we're looking at, maybe informative. And then there's a basic study looking at about 11,000 patients that hopefully will be out before too long. And again, it's a place to continue focusing and looking. One of the things I do want to come back to is the SMART trial. They did a secondary analysis of looking at patients with sepsis. So the subset out of that trial, roughly about almost 3,200 patients with septic shock that went to the medical unit from the emergency room. And certainly in the subset of sepsis, you'll see that they did reach statistical significance on both mortality as well as major renal outcomes. So again, building the evidence here and building the case that the choice of IV fluid certainly matters. And as we think about this, so this concept that the fluids are completely interchangeable, no, we really need to be thinking about, are we matching the makeup of the solution for what we're trying to accomplish with the patient? However, what I really want to spend more of the time on today is how about the dosing and the way in which we decide how much IV fluid to give? Does that matter to our patients, and should we be focused on that? And I want us to back up a little bit and think, why is it that we give IV fluid to begin with? And typically we give it for one of two reasons. Either you're using it as a carrier to get other medications into the patient, or we're using it to expand blood volume and improving perfusion and improving circulation. So I want to focus on the latter one of improving hemodynamics and improving perfusion with fluid bolus, and think about how we make the decision to administer the drug, but also how do we judge when the drug is being effective. And this is a journey we've been on for over 100 years. And if you think about this, we've had varying technologies that allow us to get close to understanding what it is we're actually trying to accomplish. But it's really only recently, in about the past 10 years, with the advent of more non-invasive technologies with the ability to measure stroke volume and cardiac output at the bedside, that we're actually able to see what it is we've been looking for all along. And again, coming back to why do we give this medication? We give this medication to expand blood volume and improve perfusion. And the way to measure that directly, and most directly, is looking at flow-based metrics such as stroke volume. And there have been recent advances here in understanding of the physiology with these technologies that allow us actually insight today that we didn't have even 10, 15 years ago. And it's revealing some very interesting physiology. One of the things that we're seeing is when you actually look at patients, okay, and you're looking to understand whether or not they get the benefit from IV fluid by expanding their blood volume and expanding their perfusion, improving their perfusion, you see fluid responsiveness only in about 50% of patients. And what's fascinating about this is true across technologies. No matter how you measure stroke volume or look at fluid responsiveness. The other thing that's also consistent is this is seen in multiple settings. This has been seen in the operating room. This has been seen in the emergency department. This is seen in the ICU with septic shock. This is seen in a variety of clinical settings. So what we're really seeing here is an interesting, I think, insight into the physiology of fluid management. And when we actually look, our patients are not benefiting from fluid expansion as often as we think they are. And certainly in those patients where they do not get a benefit from fluid, they actually may be more at risk of the challenges and the risks of volume overload, such as pulmonary edema, renal compromise, and other end organ challenges. So this is really this physiology. While it's been around forever, we've really only had visibility into it with the advent of these more recent, non-invasive techniques for monitoring cardiac output and stroke volume. Now, one of the things that's interesting is this has led to a really elegant sort of diagnostic test of whether or not being able to predict before you give the fluid, whether or not the patient is going to benefit from the fluid, whether or not the patient is going to improve perfusion. And one of the tests that's actually very good at doing this is a simple passive leg raise. And this has been well studied across different technologies and in different clinical settings, but the physiology here is very elegant and very simple. When you have someone in a semi-sitting position or a follower's position and you raise their legs, in an average adult, you'll have about 250 to 300 cc's of blood acutely coming back to the abdomen and the chest and giving a small bolus of preload to the right heart. And what you're really watching to see is how does the heart respond with that 250, 300 cc's of blood? If the stroke volume increases by about 10% or more, that's considered a positive passive leg raise. So if you're looking at each one of these lines as being an individual stroke volume as measured by echo, you'll see that when you do the passive leg raise, in this case, you'll see a rise in stroke volume, okay? And this is with putting the legs up and doing the passive leg raise. When you lower the legs, the blood redistributes and stroke volume returns back to baseline. This maneuver, as I said, when the passive leg raise is over 10% from baseline, is highly predictive that you're going to see a sustained rise in cardiac output when you administer a 500 cc bolus of saline. So passive leg raise is a nice diagnostic test of what's going to happen when you actually administer 500 cc's of fluid. And this has been studied in, again, with multiple technologies in multiple various clinical settings. You'll see that when you look at the statistics of this, the sensitivity, specificity, area under the receiver operating curve, this is a very good diagnostic test, upwards where we're talking about the way in which we use troponins or other biomarkers today. This is a very sensitive and specific test for fluid responsiveness. So really what we're doing with a passive leg raise is we're recreating the patient's Starling curve, okay? And so what we're looking at is, are they on the ascending limb of the curve? In other words, a fluid bolus of 300 cc's, do you get a rise in stroke volume index or cardiac output? Or, frankly, are you out here on the flat part of the curve where this same fluid bolus, you do not see much of a response in stroke volume? So knowing where you are on this curve is very helpful in making the decision of fluid versus pressors. Now, there are times where you can't do a passive leg raise, and certainly you can replicate the physiology of a passive leg raise by doing a fluid bolus. And this is typically 250, 300 cc's that you get in very quickly over 5 to 10 minutes, and you assess stroke volume change there. And then, of course, there are times where if you're in a code situation or near code and you're really needing to resuscitate, you can also simply trend stroke volume and look. But what you're looking for is the 500 cc bolus that you're giving. Are you seeing a rise in stroke volume? If you're seeing a rise in stroke volume, it means that you can probably keep continuing on. However, if you're not, you really want to pause and think, perhaps pressors or inotropes is appropriate would be a better therapy. And as I said, what really is engaging with this and making this difference is the ability now to measure this non-invasively at the bedside. Certainly the Starling monitor is one of those techniques available to us. And you'll see here, it'll actually step you through a passive leg raise or a bolus technique and presents sort of a Starling curve to show whether or not the patient is likely to be fluid responsive or non-responsive. Now, I want to pause because I think a really important issue here is understanding fluid responsiveness. Fluid responsiveness is an indication of what the heart is going to do when it receives extra preload or extra volume, expanded blood volume. Will it improve cardiac output and set the stage for better perfusion or not? This does not mean that the patient necessarily needs fluid. Okay, needing fluid is a perfusion question. So is your perfusion adequate? If your perfusion is adequate and you are fluid responsive, you do not necessarily need to administer IV fluid. However, if your perfusion is not adequate, okay, then certainly IV fluid is one of our early, first go-to agents, if you will, to improve perfusion. So does this approach change outcomes? Does it matter? What's the evidence? And it's building. And it's actually, what's interesting is looking both in the surgical literatures where some of this work is done, as well as I'm going to show you some work in septic shock patients, we're beginning to see really interesting sort of consistency in outcome. This is an example of a surgical trial, the Fedora trial that was performed in Europe. And this was looking at about a little over 400 patients where they used goal-directed therapy, or used stroke volume change to guide fluid administration in the operating room as well as in the perioperative period. And when they used this approach, what you'll see is they saw a reduction in AKI. They also saw a reduction in ARDS and cardiopulmonary edema, so pulmonary symptoms, and likewise a reduction in pneumonia. So I want to hold on this because these two organ systems, renal and pulmonary, are what we're seeing consistent across this approach with improvement in outcomes. In the surgical literature, there's also discussion about improvement in surgical site infections, probably in part due to edema and edema formation at the surgical site and wound breakdown. And then there's also some indication about earlier return of bowel function in these patients. But the main thing I want to focus on here is both the renal and pulmonary, because we see that crossover to the ICU population as well. So this was a study, a single center retrospective study done at the University of Kansas a while back, and they looked at, frankly, as they rolled out this approach to guiding their fluid management in their septic shock patients, they simply looked at the patients that received this therapy versus alongside the ones that did not. And what they saw, again, in this retrospective single center study was that in patients where they used stroke volume to guide fluid management, they saw reduced fluid balance at 72 hours. And that was a difference of 5.3 liters positive in their routine care versus using the stroke volume to guide their fluid therapy, deciding between pressors and fluid. They were only 1.7 liters positive. What they also saw was a reduction in ICU of 2.9 days, reduced pressor use by 32 hours, and they saw reduced mechanical ventilation. This was cut in half. The relative risk was cut in half. And then the other thing that I think was most also very interesting in this was that they saw less dialysis and renal replacement therapy required. 19% in their standard care group down to only 6.25 in their treatment group. And of course, overall in their patients, they saw 53% of them were fluid responsive, coming back to this 50% number. And if you don't check these patients to understand whether or not they're fluid responsive, you really can't predict this by other mechanisms. So this was the retrospective study. And what this is really hitting on is interjecting into the way that we take care of patients. And of course, the first question is always, do I have a perfusion problem? Do I have an impending perfusion problem? Today, we use blood pressure a lot to measure that. And I'm going to tell you, I think there are probably some challenges with that. I think flow-based measures are probably a better adjunct to certainly bring in and use when you're thinking about perfusion, because blood pressure can be sympathetically driven. Blood pressure does not necessarily equate to blood flow, and that's what's certainly important when it comes to perfusion. Not that blood pressure is unimportant, but it's not the end-all and be-all. And so I think we need to be thoughtful about how are we measuring perfusion. But that's the state of the art today. But today, if you don't believe you have a perfusion problem, sit tight. You really don't need to expand blood volume. You don't need to do anything. If you do have a perfusion problem, we always go to fluid, okay? And the issue, what we're talking about today, is the only difference in this is now we have a technique that says, will fluid work? Is fluid likely to be an effective therapy? If it is, then by all means, you can proceed with fluid. If it is unlikely to be beneficial, then you probably need to be thinking about advancing depressors or onto ionotropes if that's indicated. So one of the things that we did recently was we embarked on a multi-center study, prospective randomized study, to look at this in septic shock. And this was called the FRESH study, Fluid Responsiveness and Evaluation in Sepsis, Hypotension, and Shock. This was led by Ivor Douglas, and we performed this here in the US as well as in Canada. And the high-level takeaway was that the use of dynamic assessments, a passive leg raise, to guide fluid administration appears to improve the outcomes for septic shock patients compared with usual care. The other thing also is that using this approach, certainly we did not see any safety signals, and it was able to generate a lower net fluid balance alongside the reductions in risk in renal failure, a risk of renal failure as well as respiratory failure in the study. So we appear to show certainly an improvement in outcomes, and certainly we don't have any safety signals that arose in this that would give you pause. So why is FRESH important? It's really the first randomized controlled trial to demonstrate improved outcomes using dynamic measures in septic shock. And it builds on physiologic studies and retrospective studies, both in surgical patients as well as some limited studies in septic shock. As I said, we performed this at 13 sites here in the US and the UK. We had it was a great group, investigator group, and this study was just published this past fall in Chest in October of this year. So what did it show? What we saw was a decreased 72-hour fluid balance. Okay, the treatment group was only 0.65 liters positive versus the control group a little over 2 liters positive. So we saw a fluid reduction of about 1.3 liters in the treatment arm. And this was statistically different between the two arms of the trial. We also saw a reduction in renal replacement therapy, a combination of dialysis as well as ultrafiltration. And similar to what was seen at KU, we saw the control group was about 17.5% initiation of renal replacement therapy. In the treatment group, we only saw this in about 5.1% of patients. Likewise, we saw a reduction in mechanical ventilation with less respiratory impact. The control group, about 34% of the patients were intubated, where in the treatment group, only 17% of the patients were intubated during the study. We also saw a strong trend towards a reduction in length of stay, although it did not reach statistical significance in this trial with a p-value of 0.01. The control group was at 6 days, and the treatment group was down to about 3 days. The other thing that was interesting that we saw was when we looked at a composite measure of discharge home versus either death or discharge to augmented care, we had a higher percentage of patients being discharged home. In the treatment group, roughly 63.9% of the patients went home directly from this hospitalization, where in the control group, only 43.9% were discharged to home. So we saw definitely a difference in discharge location between the two arms. So the study, while I went through the outcomes, the study was really, we looked at 124 patients. We had 2-to-1 randomization in the treatment arm to enrich the treatment arm, and we had 41 patients in the usual care arm. We enrolled these patients in the emergency room with refractory septic shock prior to the administration of 3 liters. So we wanted these patients enrolled prior to a full 3 liter of administration because we wanted to make sure we were having impact on fluid management after that. Once they were enrolled, passive leg raise was used to assess any additional resuscitation decisions, either fluid or pressors. And that carried out over the next 72 hours in the ICU or until ICU discharge. And we were really using passive leg raise to help guide the clinical decision of, do I give fluid or do I give pressors? And so I'll take you through the protocol and sort of show you a little bit what that was. And while this is a little bit of an eye chart and it's hard to read, you'll see that the step into this decision algorithm was really a clinical decisions made to treat the patient with fluid or vasoactive medication. So the clinician at the bedside was making the decision that they wanted to administer either fluid or pressors that they believed they needed to resuscitate the patient. We used mean arterial pressures of less than 65 or systolic less than 90, trending lower. Urine, lactate could drive this decision. And you'll see that it was basically a very broad inclusion into this. So once that decision was made, we asked that a passive leg raise be performed. And if the stroke volume change was greater than 10%, you would proceed down the fluid arm. Likewise, if the stroke volume change was less than 10%, you were unlikely to respond to fluid. We asked you to titrate vasopressors. And vasopressors in this case were primarily norepinephrine was used, as is, I think, more common clinical practice when it comes to septic shock. You'll see that we allowed crossover in this, and we asked with the fluid arm that after you passed either 500 or a liter, that you would please repeat the passive leg raise to make sure that you continue to be fluid responsive. Likewise, with norepinephrine and a little bit of beta effect, we wanted to make sure that if you were proceeding down that arm and you titrated up your vasopressors, that you also continued to understand whether or not you were fluid responsive and not just simply blindly enter one arm. So there was crossover between the two arms based on coming back and assessing fluid responsiveness. So as I said, what we saw was a reduction in fluid balance at 72 hours. We also looked at, as we said here, length of stay, the number of days with ventilator use and vasopressor use. The main thing here I wanted to show with the forest plots, as we looked at all of these, certainly nearly all of the secondary outcomes and the other issues that we were looking at tended to favor the intervention group as opposed to the standard care group. And so certainly we saw a trend, towards improvement in these sides, not only in length of stay in the hospital, but when we also looked at the fluid, you'll see that that hit statistical difference with this when we included pre-induction, pre-trial fluid at both amount of fluid given as well as fluid balance. We were really looking at less fluid being administered, driven by the treatment algorithm. Here, looking at additional outcome measures as we looked in the trial, looking at serious adverse events, looking at a combination of MACE events, MACE or death, as well as discharge locations and readmissions. All of this tended to favor the group that underwent intervention. Actually, this point here, which is favoring the standard care, is a positive readmission rate. Here, it's negative readmission rate. So if you're more likely to be admitted, trending here, if you were in the standard of care arm. So when you're certainly looking at safety signals and that, everything tended to line up, as I said, and other signals as well, tended to line up on par, with the intervention group. One of the pieces of evidence I would just want to bring up here, this was an economic analysis. It was done back on that retrospective trial at the University of Kansas. And they did an economic analysis, and most of this economic value is driven by the length of stay, reduction in mechanical ventilation, and reduction in renal dialysis and renal replacement therapy. The University of Kansas in their economic analysis came up with a savings per treated patient of about $14,000, almost $15,000 per patient treated. And the only point I'm bringing this up is when you look at the outcomes here, we haven't done a formal economic analysis on FRESH, but certainly the outcomes are very similar, and we would expect these economic values to hold as well. So certainly as what we're seeing here, I think the trend towards the outcomes, not only are we seeing positive clinical outcomes, but these also drive, in all likelihood, significant underlying economic value as well. So what are the key takeaways from FRESH? I think at a high level, what we're saying is that we've demonstrated here, I think in the study, that dynamic measures, their use in shock is safe. It does appear to reduce fluid balance at 72 hours and the amount of fluid actually administered. And we're seeing improvement in outcomes, certainly in less mechanical ventilation and less renal replacement therapy. And more of these patients are being discharged home. This is, again, sort of based on and built upon other literature, certainly confirming what was seen at the University of Kansas and building on surgical literature. And the economic outcomes that we saw at the University of Kansas, certainly based on the similarity between the trials, some of these may transfer over to FRESH as well. I think the FRESH trial also raises a couple of very interesting questions. And one of the things is when we actually look at the fluid difference between the FRESH study and other studies that have been done, if you actually look at the fluid difference back earlier, we were about 1.3 liters different between the two groups on average. This was down from what we saw at the University of Kansas, about 3.5 liters. And what's interesting is when you actually look at some of the surgical studies, such as Fedora and others, the total amount of fluid is very little difference between the two control groups, or between the two groups, the treatment group and the control group. And I think what we're actually starting to see, perhaps, okay, and this is a question I think to be explored, is it not so much is it not only important how much fluid we give, but the patient's status at the time in which we give it. So if we're giving fluid to a patient that is not fluid responsive and not able to handle it in improving perfusion, they're simply increasing lung water or interstitial edema or venous pressures to the kidney. Is that the timing of fluid? Is it equally as important matching that to their physiology? And so I think that's something, a further area to be explored and understand. The other thing I do think we need to be very thoughtful about, this construct that certainly I was taught as a medical student, and some of my colleagues I think still tend to adhere to, this concept of, well, load them up, you can always take it off later with Lasix. I think what we're seeing is that is indeed not the case. And actually there's data within FRESH that tends to support that too. Because the fluid removal in the control group within FRESH was actually more aggressive than it was in the treatment arm. So there wasn't, diuretics tend to be used more in the control group. Certainly, renal replacement therapy was used more. And despite this effort, what we saw was, these patients did not necessarily do better when it came to mechanical ventilation than patients that, patients were treated appropriately up front. So I think, there's certainly more work to be done in this area, more questions to be answered, but I think that becomes a sort of exciting areas as we move forward. So how does all this fit with COVID? And is COVID, really a different animal, than, and how should we be thinking about fluid in COVID? And I think what's interesting is to watch watch us as a medical community learn so quickly and adapt with this disease. Certainly back in March of 2020, the World Health Organization in their recommendations were recommending the use of dynamic measures and fluid responsiveness to guide, volume administration. And we're recommending passive leg raise and serial stroke volume measurements. I think also one of the things we saw very early in COVID was, our use of high PEEP and, pulmonary measures to treat this certainly may have been contributory towards some of the higher renal failures that we were seeing in the case as well when you get into the renal perfusion and hemodynamics associated with high PEEP. The other thing as we think about, COVID as being viral sepsis, we also need to be thinking about, and looking at how our fluid management transfers over to these patients, I think is really critical. Certainly when we look at the more recent surviving sepsis guidelines with COVID-19, there is a suggestion here that, again, we should be thinking about fluid responsiveness as we treat these patients with volume and volume resuscitation. And certainly we should be thinking about crystalloids and recommending probably the use of balanced crystalloid solutions in these patients as well. So if we're going to step back and take away, so where are we with fluid management today? I think fluid management is clear, definitely impacts mortality, and it does deserve another look and attention from us as clinicians at the bedside today. Certainly our choice of IV fluid, there's continuing building evidence that we should be using the compound or the drug of choice to treat specific, issues with the patient, and certainly normal saline used for large volume resuscitation or, volume resuscitation. We should be thinking twice probably before we use that aggressively. And then the other piece that's really coming on board here is we should be thinking about how we dose IV fluids. And we want to make sure we're dosing IV fluids and using IV fluids when the patients are receptive to the benefits of that therapy. So with that, I'll close. And Jen, I guess we'll move over to the live Q&A session.
Good morning, everyone. We hope that you enjoyed Dr. Hansel's talk. We have some questions that came in through the live Q&A that we would like to propose for Dr. Hansel to review. So the first question is there any concern with utilizing balanced fluids such as lactated ringers or Plasmalite in patients with elevated intracranial pressure or cerebral edema given the lower osmolality compared to normal saline?
Yeah, thank you for raising the question. It's an excellent point. And I think the whole point around decision-making around the fluids is that each of these fluids has different characteristics and different indications, and we should be using them for different indications. So absolutely, the more hyperosmolar, hypertonic aspect of normal saline, may indeed be beneficial in patients with intracranial, hypertension or elevated ICP. That's someone that, frankly, going with a more balanced or more, plasma-like solution may not be appropriate. So again, the key takeaway there is know your patient's condition and being thoughtful about the composition of the fluid that you're using to address the patient's needs. So absolutely, thank you for the question.
Okay, next question. Can you please discuss the lower fluid balance in the FRESH study, a difference of 1.37 liters between the treatment and the control group, compared to the Kansas University study with a difference of 3.9 liters?
Yeah, I think this is one of the more interesting aspects of the study because you start looking at the difference in fluid balance between the two arms, the actual fluid balance. you know, it certainly at a mean and median level starts getting fairly narrow. And in fact, when you go to the surgical literature and you look at some of the studies like Fedora that I had mentioned, when you actually look at the two arms of the study over the operating room and into the recovery room, so, you know, relatively short period of time, actually the fluids balance out and there's not much of a difference in fluid administration between the two arms of the study. And so, I mean, I think understanding that and teasing that out is really important. I suspect what's going on there is this is more about giving fluid when the patient is receptive to it and can benefit from it, and not so much that this is just a matter of, it's a technique of giving less fluid. And I think it's more about matching the therapy fluid to the patient's physiology and their ability to benefit from it. I think, you know, the other thing that's really kind of interesting about the passive leg raise technique when you dig into it, and we saw this certainly as we did some additional analysis in the treatment arm, and you'll see you see some of this in the fresh paper, and then some of this was actually in abstracts that we're working to getting into a formal publication. But fluid responsiveness is really an interesting sort of measure of cardiac reserve. And it's telling us about the receptiveness and the resilience, I think, of the cardiac system, you know, at that particular moment. So while it's useful in guiding fluid, I think it's an underlying indicator of you know, cardiac reserve, cardiac resilience. And so again, this is not about just giving less fluid. It's really identifying, I think, cases where the fluid is beneficial and then where it is not helpful in improving perfusion. You know, what's happening, you're theoretically, you're increasing interstitial edema in the kidney, increasing lung water, and simply, you know, not providing benefit to the patient. So I think this is a really interesting thing to continue to watch and look. And again, I think you go to the surgical literature, what's fascinating to me when I first was looking at this, you know, about 6 years ago, there isn't a lot of difference between the two arms of some of the surgical studies in actual amount of fluid administered, so.
Excellent. Okay, next question. What will FRESH lead to next in the literature?
Well, I think this is really just at the tip of the iceberg of understanding better, you know, fluid physiology and where we can go with this. You know, the dynamic measures have been shown to be beneficial in surgery patients and surgical you know, areas. We're seeing it in sepsis. You know, we're seeing this physiology brought forward in other settings too, whether it's ARDS, patients arriving in the emergency room, you know, in trauma. There's this degree of patients that are not fluid responsive. And so understanding how this plays through in different patient groups, I think is one, you know, avenue here. I think the other thing to me that is really fascinating, if you step back and sort of take a higher look at this, we've had fluid for 100, 150 years, and we finally have a tool that lets us, you know, actually dose the fluid in a way that's physiologically responsive. And so where do we, you know, what's the benefit of that? Where does it matter? Where should we be applying it? I think is some of the work that we have to go forward with. I think also understanding the basic physiology. It's an area ripe for additional investigation.
Thank you. Perfect. Next question. What was the response of the site investigator teams to adapting the passive leg raise at their institution?
Yeah, you know, it was actually pretty well received and relatively easy to train. I think the technology also typically will step you through the process, so it's not a you know, heavy learning curve or something you need to doesn't take a long time to adapt or to adopt. And I think the other thing we saw was the care teams, you know, actually found the information really useful. And so I think from the bedside nursing perspective, there was a lot of engagement. They felt that they were better able to understand their patients and better able to advocate for their patients. And likewise, I think for the care team overall, you know, this is, it's a relatively simple test to do. It doesn't take that long, and it's actually incredibly revealing about the physiology. So overall, I think it was a win, and yeah, it went very well, surprisingly well in bringing the bedside teams along.
Excellent. Okay, final question. What is the evidence in COVID-19 that using dynamic measures can have benefit?
Yeah, you know, the evidence, I'll be honest with you, the evidence currently is light. You know, we're learning about COVID and learning on, you know, sort of how we need to take care of these patients, and our care of these patients here in 2021 is so different than it was even, you know, less than a year ago. And I think when we look at the fluid dynamics, we see the fluid physiology across multiple settings. So we see it in the OR, we see it in ARDS, we see it in septic shock, we see it in these different settings. And certainly I think there's a perception that COVID, certainly the severe COVID, pro-inflammatory reaction that you have really does behave as sepsis. And so it's the leap there that indeed, why would the fluid physiology not apply in this setting? So I think there's a strong leap there in making that. The other thing is we do have a study ongoing, a registry study where we're collecting data, hemodynamic data and fluid data in these patients. And I think really, hopefully, being able to answer that question definitively before too long. I do think you look at the difference in care back in March and April versus today. And one of the things we were doing, back when this first hit in March and April of 2020, we were using high PEEP, really restricting fluid, and we're delaying mechanical ventilation today. We're using less PEEP, I think, overall. And so with that, you're seeing less renal impacts from, the hemodynamic impacts in this. But I still think managing these patients better hemodynamically and managing them better, managing the fluid to the point where to make sure that they're physiologically responsive when the fluid's administered, will provide value. But the answer to that, hopefully, we'll be able to answer that before too long.
Thank you. That was our last question from the team. So we'd like to say thank you to everyone for spending your early morning with us. We will be updating our description, so if you have any questions, you'll be able to reach out to us through email, and we would be delighted to take any further questions or hear any other thoughts that you may have. Thank you so much, everyone.